All right, diving deep today, we're tackling how doctors treat acromegaly, and we've got a ton of research to go through. We really want to figure out, what treatments are working best and why.
Yeah, and it's not as simple as just bringing down growth hormone levels. There's this key marker, IGF-1, and getting that back to normal. Well, that can be tough.
So there's a real balancing act involved.
Mm-hmm.
But before we get into the how, maybe a super quick recap. Acromegaly, it all starts with a tumor in the pituitary gland. That's like the body's tiny control center for hormones, right?
Exactly. It's this tiny gland, sits right at the base of the brain, and when a tumor pops up, it can make way too much growth hormone. That's what causes all the changes we see in acromegaly, like different body parts getting larger.
And you know what really struck me going through all this research? Even if treatment is perfect, some bone changes from acromegaly, they're irreversible. We'll definitely have to circle back to that.
For sure. That's one of the toughest things to deal with when you're managing acromegaly.
So let's talk solutions. What's usually the first step?
A lot of times, the go-to is surgery, specifically a procedure called transsphenoidal surgery.
Transsphenoidal surgery. Wow, sounds intense. Like something out of a sci-fi movie almost.
It might sound a little scary, but it's actually minimally invasive. They go in through the nose to reach the pituitary gland.
Wait, through the nose? You're telling me they're going through the back of the nasal passages to the brain? It's incredible what surgeons can do. But how often does it actually work?
Well, it really depends on how big the tumor is. If it's a small tumor, like what we call a microadenoma, success rates can be really good, like 80 to 90%. But for larger tumors, the macroadenomas, it's less than 50%.
I see, so size is a big deal. But here's the thing I thought of right away. Even if this surgery is a success, can acromegaly come back?
Unfortunately, yeah, there's always that chance, even years later. So anyone who's had this surgery, they need to be monitored long term. It's super important.
It's not just like you're done, and that's it. Regular checkups are a must. Speaking of not so fun things, what about risks from the surgery itself?
There are some, like any surgery, but they're pretty rare, especially when you have a surgeon who's done a lot of these. You could have things like hypopituitarism, which basically means the pituitary gland isn't making enough hormones.
Sounds like that could cause a whole bunch of new problems, like a domino effect.
Yeah, that's right. Hypopituitarism can throw off other hormone levels, and then you might need more meds and more monitoring. There's also diabetes insipidus, but that's less common. It messes with how your kidneys conserve water.
So surgery, it's an option, but not always a cure. And it has its own risks. What if surgery isn't right for someone, or doesn't completely fix the problem? What then?
That's where medication comes in. There are actually quite a few meds that can help control those growth hormone levels.
All right, let's hear about this medicine cabinet. What are we talking about here?
One of the most common types are somatostatin analogs.
Somatostatin analogs. Okay, for those of us who aren't doctors, break that down a bit. What are they and how do they work?
These are actually pretty cool. They're like a copycat of a hormone your body already makes called somatostatin. Somatostatin's job is to put the brakes on growth hormone. So these meds, they bind to specific receptors, and that helps cut down on growth hormone production.
So they trick the body into slowing down its own growth hormone factory. Working smarter, not harder. But do they actually work well?
They're pretty effective. Studies show that they can bring IGF-1 back to normal for a lot of patients, sometimes even as high as 75%.
That's good to hear. But, we got to talk about it. Every medication has them. Side effects. What are we looking at here?
You're right. No med's perfect. Some common ones with these are like nausea or changes in bowel habits, but that usually gets better after a few weeks.
Okay, so nothing too terrible. Anything more serious to worry about?
One thing to watch out for is gallstones. These meds can affect how the gallbladder works, so doctors keep an eye on that.
Oh, great. Gallstones, just what you want to add to the mix. Anything else about somatostatin analogs that stands out?
One really interesting thing is that they can sometimes actually shrink the tumor.
Now that's a nice bonus. Multitasking treatment. Are there other meds we should be talking about?
Yeah, a couple others. Dopamine agonists are another option, like cabergoline. They're not quite as effective as the somatostatin analogs, but good news, they're pills, not injections.
Okay, well, that's definitely a win for convenience. Do they usually get used alone or with other treatments?
They can be used on their own, but a lot of times they're added if someone's already on a somatostatin analog and their IGF-1 is almost at the target, but needs a little extra help to get there.
So it's a fine-tuning tool.
Exactly. And being a pill makes it a pretty easy addition to the routine.
Makes sense. Now, there's another medication I saw in the research, pegvisomant. What's the deal with this one?
Ah, pegvisomant. This one's a little different. It's what we call a GH receptor antagonist, and it works a little differently than the others.
Okay, I'm listening. How does it do its thing?
So instead of trying to lower how much growth hormone is being made like the others, this one tackles the problem from a different angle. It blocks growth hormone at the receptor level.
So it's like intercepting the growth hormone before it can do any damage, cutting off communication.
You got it. Prevents growth hormone from binding, which stops it from, making things grow.
That's fascinating.
Yeah.
Sounds really targeted. But if it's not affecting how much growth hormone is made, how do you know if it's working?
Good question. With this one, we can't just look at growth hormone levels. We have to keep a closer eye on those IGF-1 levels.
So regular blood tests are even more important. Any special risks to watch out for with this one?
Since it blocks the action but not the production of growth hormone, there's this theoretical risk that the tumor could keep growing. But I want to stress that's very rare.
Rare, but good to know. Sounds like regular MRI scans would be important to make sure the tumor's not doing anything sneaky. Would you ever combine this one with other medications?
Sometimes, yeah. We might combine it with a somatostatin analog, especially if the analog alone wasn't enough to get those IGF-1 levels where they need to be.
It's like a double whammy. Now, we've talked about surgery, all these different meds, but there's one other treatment option, radiation therapy. When does that come into play?
We usually think of radiation as a last resort.
How come? Is it the side effects?
Side effects are a concern, for sure, but the main reason is that it takes a really long time for radiation to work, like years. Surgery and meds are more immediate, but radiation, it's really gradual.
Definitely not a quick fix. Are there different kinds of radiation? And what are the pros and cons?
Two main types. There's fractionated radiation, which is given in a bunch of smaller doses, and then there's single-dose radiation, which is all at once. The fractionated kind lets us target the tumor more precisely, which is crucial if it's close to something delicate, like the optic nerves.
Minimizing collateral damage. What about single dose? What's good about that one?
The main plus is it's convenient, just one treatment. So logistically, that can be a lot easier for some people, but it's not for everyone, especially if the tumor's in a tricky spot.
So it's all about weighing the pros and cons. Now, the big question, I bet everyone's thinking, what about long-term side effects from radiation?
That's a huge factor to consider with any kind of radiation. One of the biggest ones is that hypopituitarism, again. Radiation can affect the pituitary gland, and that can lead to not having enough of other important hormones.
So you're solving one hormonal problem, but maybe creating others. Are there any other long-term risks?
Yeah, there's a very small but real risk of getting a second tumor years down the line. And there's even some research that suggests it could impact how long you live. It's a tough decision. You have to weigh all the potential good and bad with your doctor.
This is heavy stuff.
Yeah.
Maybe we need a later topic for a sec. What about pregnancy? How does acromegaly play into that, and what are the special things to think about with treatment?
That's a great question, and an important one. Because acromegaly can definitely make things more complicated during pregnancy.
How so?
Well, first of all, the hormone imbalances can affect whether you can even get pregnant in the first place. And then if someone does get pregnant, there's a higher risk of complications.
So if you have acromegaly and want to have a baby, planning and careful management are key. What about the medications? Can you stay on any of them while pregnant?
Depends on the med. Some, like the somatostatin analogs, we usually stop those during pregnancy because they could affect the baby's growth.
So you're balancing the mother's health with the baby's health. Any other things to keep in mind for pregnancy with acromegaly?
Ideally, before even trying to get pregnant, growth hormone levels should be under control. And then once pregnant, frequent checkups are super important to make sure both mom and baby are doing okay.
So being proactive, staying on top of things, makes sense. But with all these potential complications, I'm curious, do most pregnancies actually go okay for women with acromegaly?
That's a great question. And the good news is, yes, most of the time things are fine. But of course, close monitoring throughout the pregnancy is key.
That's reassuring. We've talked about initial treatment options, but what about in the long run? What's long-term management like for someone with acromegaly?
It involves regular checkups, keeping an eye on those IGF-1 levels, and maybe adjusting medication doses over time. It's really about making sure the treatment plan is working for each individual person and making changes as needed.
Sounds like a real partnership between the patient and their doctor, working together to stay ahead of things. What about those other hormone deficiencies we talked about earlier, the ones that can happen as a side effect of treatment? How do you manage those?
Yeah, that's where things can get tricky. Sometimes treating the acromegaly can actually lead to a growth hormone deficiency, which might sound strange because the original problem was too much growth hormone.
So it's like the pendulum swings too far the other way. What does that mean for someone who had acromegaly?
It can mean a whole new set of symptoms, and they might need to start hormone replacement therapy. There's actually some debate among doctors about whether to treat growth hormone deficiency in these cases.
What are the arguments on each side?
Some doctors think that replacing the growth hormone is really important because it can improve quality of life and reduce some of the negative effects of the deficiency. Others are worried about the risks of taking growth hormone long term, things like an increased chance of heart problems.
So no easy answers. Sounds like a very personal decision, weighing the good and the bad for each person.
Exactly. And that's why it's so important to be open with your doctor and have honest conversations so you can make the choices that are best for you.
Wow, we've covered a lot today. Surgery, medication, radiation, even pregnancy. What's the one thing you want our listeners to remember?
I think the most important thing is that acromegaly is complex, but it can be managed. With the right treatment, which is always tailored to the individual, people with acromegaly can live long and fulfilling lives.
That's a great message. But I know we have more to discuss, especially about those irreversible bone changes that can happen. We'll be back in the next part of this deep dive to talk about that. And we'll also explore some of the newest research and where acromegaly treatment might be headed in the future.
You're right, we've got more to unpack. Let's dig into those irreversible bone changes. They're a big part of understanding what acromegaly can do in the long run.
Yeah, this is something that really made me think when I was reading through all the research. Why are some of these changes permanent? What's actually happening to the bones?
It's all about how that extra growth hormone affects bone growth. Acromegaly, it doesn't make bones grow longer. They get thicker, wider.
So it's not about height, it's more about the bones getting, like, bulkier.
That's a good way to picture it. And the thing is, once they've thickened up, they don't go back to their original size, even if you get the growth hormone under control.
So that explains why someone's hands or feet or even their face might still be enlarged after treatment, even if it was successful.
Exactly. And those changes, unfortunately, they can lead to other problems. Pain, stiff joints, even trouble moving around.
Makes you wonder if there's any way to reverse those changes someday. Is there any research being done on that?
That's a question a lot of researchers are trying to answer. There are studies going on right now looking at new treatments that could maybe address those bone changes. It's a tough nut to crack, but there's definitely hope for the future.
I hope so. Now, you mentioned earlier that acromegaly can increase the risk of polyps in the colon. I want to make sure we talk about that. It seems really important, especially for catching things early.
Absolutely. It's a reminder that if you have acromegaly, you need to be proactive about getting screened.
What's the link between the two? Why does acromegaly make these polyps more likely?
We don't know for sure yet, but the main theory is that all that extra growth hormone could be what's making the polyps grow in the colon.
So it's not just bone growth. Growth hormone has these wider effects. What does that mean practically for someone with acromegaly? Should they be doing anything different when it comes to colon cancer screening?
They need to be more on top of it than the average person. Everyone's supposed to start getting colonoscopies at age 50, but someone with acromegaly, they might need to start earlier, especially if colon cancer runs in their family.
Makes sense.
Mm.
And how often should they get screened? Same as everyone else or more often?
Usually every 3 to 4 years, but it's really important to talk to your doctor about it. They can help you figure out a plan based on your specific risks and medical history.
So it's not one size fits all. You really need to have that conversation with your doctor. Advocate for yourself. We've talked about how acromegaly is treated right now, but what about the future? What's coming down the pipeline in terms of research and new treatments?
That's what's so exciting about this field. The research is always moving forward. Scientists are working on new meds that target different parts of how growth hormone is made and how it acts in the body, looking for more precise ways to control the disease.
So we could be seeing even more targeted treatments with fewer side effects. That would be incredible. Are there any other areas of acromegaly research that you're really excited about?
Oh, definitely. There's a big push to figure out how to detect acromegaly earlier. Imagine if we could catch it in the very beginning, before those permanent changes happen. Early treatment could completely change the course of the disease.
That would be amazing.
Yeah.
It makes you wonder what other breakthroughs are just around the corner. Do you think we'll ever be able to reverse those bone changes?
It's hard to say for sure, but I wouldn't rule it out. Science is always advancing, and there's so much we're still learning about acromegaly. Even without reversing the bone changes, the progress we've made in treating it is huge.
Absolutely. The researchers, the doctors, the patients, it's all leading to incredible advancements. Before we move on, anything else about the future of acromegaly treatment that you want to leave our listeners with?
I think the biggest thing to remember is that even with all these new therapies being developed, the most important thing is a good relationship between the patient and their healthcare team.
Couldn't agree more. Communication, making decisions together, trust, those are all crucial for navigating something as complex as acromegaly. Now, we've talked about a lot today. What's the final message you want our listeners to take away from this conversation?
I want to emphasize that acromegaly is manageable. With the right treatment and ongoing care, people with acromegaly can live long, healthy, and fulfilling lives. And to anyone listening who might be dealing with this themselves, you're not alone. There are amazing resources and support systems out there.
It's so important to remember that. Connecting with others who understand what you're going through can make such a difference. We'll be back in just a bit to wrap up our deep dive into acromegaly treatment. But first, all right, we're back, ready to wrap up this deep dive into acromegaly treatment. We've gone over a lot. Surgery, medications, what it's like to manage this condition long term. Phew.
Yeah, we've dug into some of the tough stuff too, like the bone changes that can't be reversed and those extra risks for other health problems.
But even with all that, there's been this sense of hope,
Uh-oh.
because research is always pushing forward. There's so much potential for breakthroughs.
Definitely. It's really inspiring to see how dedicated the researchers and doctors are. They really want to improve life for people with acromegaly.
And we can't forget the patients. Their courage and resilience, that's what drives progress.
Couldn't agree more. And to anyone listening out there who's dealing with acromegaly themselves, remember, you're not alone. There's a whole community of support.
Absolutely. It can make such a difference to connect with others who really get it. Now, before we say goodbye, is there anything else you think our listeners should keep in mind as they learn more about acromegaly?
I think the most important thing is to remember that knowledge is power. The more you understand about this condition, the better you'll be able to make decisions about your own health. Really be in control.
I totally agree. Be curious, don't be afraid to ask questions, and be involved in your own healthcare. Well, that brings us to the end of our deep dive.
It's been great exploring all this with you. It's a really fascinating topic.
Thanks for coming along on this journey with us. We hope this has been helpful, maybe even inspiring.
And until next time, keep on learning, keep diving deep.
Keep those brains buzzing, everyone.